Hi, and welcome to this webinar where we will be discussing HER2 testing in gynecologic cancers and talking about how that HER2 testing can lead to treatment options for our patients. I am Dr. Jennifer McDonald. I am an oncology pharmacist at the Medical University of South Carolina and particularly specialize in gynecologic cancers. Also joining us today is Dr. Saeed, who is Assistant Professor of Pathology and Director of Cytopathology at VCU Health in Virginia. Our objectives for today's presentation will be to review Destiny pan-tumor data and other relevant trials for HER2 targeted therapies in gynecologic cancers, and then describe the HER2 testing methods available, as well as what scoring we use in gynecologic cancers to determine what therapies we can use, and then apply that to practical patients about specimens, how they need to be handled and scored and reported for gyn-onc teams, and then understand how those reports help us make treatment decisions for patients based on HER2 results. So just to set the stage before we get into all of the pathology that Dr. Saeed is going to go over with us, we currently have a lot of different available HER2 targeted therapies for the treatment of gynecologic cancers. Historically, trastuzumab was one of our first HER2 targeted therapies and was implicated for treatment in endometrial cancer for patients who have carcinosarcoma or serous histologies with HER2 testing that was 2+, that was confirmed by FISH testing, and particularly for women who had primary kind of upfront treatment for advanced stage disease showed a progression-free survival benefit that was definitely significant at about 9 months. Then we had Destiny pan-2, which was obviously recently came to the market and was FDA approved. That was a large basket trial that had all sorts of cohorts. But in the gynecologic cohorts, we saw a very significant objective response rate across endometrial cohorts, ovarian cohorts, and cervical cohorts that were IHC 2+ or more positive with no reflex FISH required. There are ongoing trials for 2 newer agents to use, at least for gynecologic cancers, including pertuzumab and DB1303, but those are to be determined, so we won't be discussing those in large amounts today. Really, the goal of this presentation is for you guys to know that there are a lot of HER2 options in gynecologic cancers, and HER2 is here to stay. And their uses and available options for gynecologic cancers will continue to expand. So it's really important for us to understand the pathology, how we ensure we have adequate HER2 testing, and then how we use that to make treatment decisions. So with that, I will turn it over to Dr. Saeed.
So in discussing HER2 from the perspective of a pathologist like me, the landscape of HER2 targeted therapies continues to evolve, and it's often difficult for us in pathology to differentiate the various agents that are being used for therapy and the scoring system that was used for HER2 in some of these trials. So this trial specifically, the Destiny pan-2, looked at HER2 expression through immunohistochemical staining and used guidelines from ASCO and CAP for gastric cancer. So that's really important to remember. Gastric cancer that scored 2+ or 3+ was used with no reflex testing with FISH or fluorescence in situ hybridization. In the GYN tract, pathologists are probably more familiar with trastuzumab and the use of HER2 in endometrial serous cancer or carcinosarcoma. For this, many of us use the breast scoring system, while others use another proposed criteria specifically intended for the GYN tract based on endometrial serous carcinoma. It's not yet mandatory that we use that reporting system, but CAP, College of American Pathologists, our accrediting body, usually establishes when pathologists are required to use a certain report type for interpretation. So this is certainly something worth discussing with your pathology team or during your tumor board, specifically which drug you intend to use and the scoring system that should be applied by the pathologist. For example, gastric, breast, or other. I'm sure most pathologists like me would appreciate this additional information. In terms of pathology interpretation, I wanted to quickly highlight the complexity of scoring from our perspective. This is a little bit of a busy slide, but I just wanted to highlight that when we say the cutoff is 2 plus, this is taken directly from the CAP, it's thought to be equivocal in terms of the immunostaining. So the percentage of positive tumor cells varies widely depending on the system you're using, whether it's GI or GYN. So because that cutoff changes for 2 plus, it's really important to know which system that you need to apply for that specimen. So in here, you can see that HER2 expression greater than 10% of tumor cells or more will be scored as a 2 plus, and it can be, when strong, it can be a 3 plus as well. So again, like I was mentioning, the proposed endometrial serous system, the 2 plus has a different cutoff to be considered equivocal, and reflex testing to FISH is usually ordered. So again, very important to emphasize the therapy you're considering using, and then the pathologist would know what type of HER2 scoring needs to be performed. So here's an example of the standardized reporting systems through the American College of Pathology. These reporting templates are in use and should be in the pathology report where you would see the synoptic reports and the staging information. As you can see, this is the template that exists for GYN specimens, and it very specifically is mentioning the criteria for the endometrial serous criteria. So this is not the same as the gastric criteria. So again, something that you would want to give your pathologist heads up about when they're scoring for HER2. So this figure is just meant to highlight that for us as pathologists, we're often doing reflex testing depending on the results of our scoring. As you can see on the bottom, it's mentioned that for an IHC score of 2 plus, ISH testing is performed, but FISH testing is not recommended here. This is different from what we do for HER2 in the breast. So that is also another point to discuss with your pathology team, what type of reflex testing that's required for the drug that you intend to use. And as I mentioned, there are several testing modalities for HER2. Thus far, we've discussed immunohistochemistry or IHC, but there are also FISH, fluorescence in situ hybridization, and ISH in situ hybridization. And depending on the cancer type, different tests are performed when there's a 2 plus score with HER2 or equivocal staining to confirm typically the presence of a HER2 amplification. Another important part about HER2 testing in general is the specimen processing. So most pathology labs are often documenting the formalin fixation time and cold ischemic time for breast cancers, but are unlikely to be documenting it for GYN specimens. So based on what we know from breast cancer, the cold ischemic time, or the time before a specimen is put into formalin, it matters, and it should be shortened if possible. 1 hour may not be possible, but the shorter the time, the better for the scoring. And the time in formalin is also something that pathology labs can document if needed as well. So if you notify the lab in advance, it would allow them to be able to plan ahead and to make sure that the specimen that's going to be used for HER2 testing or scoring meets the criteria for the formalin fixation times. All right, back to you, Dr. McDonald.
Awesome. Thank you so much. A couple of things that I just want to highlight before we kind of wrap up and conclude. You know, when you're talking about HER2 therapies, a couple of important things to remember. The original HER2 targeted therapies like trastuzumab and pertuzumab that were used in breast cancer, you know, needed a lot of confirmation, as was mentioned, for equivocal staining to confirm HER2 amplification in order to improve the likelihood and chance of response. That could potentially be a little bit different when you look at antibody drug conjugates, those like trastuzumab deruxtecan, when you're using them in tumor types. And a lot of that is because there's tumor heterogeneity, right? So one tumor sample may be HER2 low or even HER2 negative, but another sample of tumor cells may be a much higher expressor of HER2 and may still confer response. So there can be kind of sampling errors, if you will, and just heterogeneity of the tumor could mean that antibody drug conjugates can still work in people with lower expression levels of HER2, hence why we have some trials ongoing in like HER2 low breast cancer for antibody drug conjugates, as well as HER2 low gynecologic cancers. So just wanted to mention that a lot of that has to do with the fact that antibody drug conjugates have what we call a bystander effect. So they also kind of, I teach people they're kind of like a bomb. Once they reach the location, they kind of explode and they do cause neighboring tumor cells to die. So again, there's a lot of investigation ongoing in that area right now to determine if some of these HER2 low expressors can potentially benefit from antibody drug conjugates that target HER2. But to wrap up, I just want to conclude with, the testing that Dr. Saeed mentioned is extremely important, and the cutoffs that you're using, knowing which drug you are looking for potential therapy for the patient, as well as whether you're using the gastric scoring and if you should be reflexing to something like FISH or ISH testing to confirm HER2 amplification. For someone who's newly diagnosed with endometrial cancer, I think it's important to do HER2 testing to see if they might be eligible for trastuzumab or other ongoing clinical trials. There's a trastuzumab-pertuzumab clinical trial that would need appropriate testing with HER2, and that would require equivocal to go through FISH testing. If the patient did not have FISH, but just had IHC that was 2+ or 3+, trastuzumab deruxtecan in the recurrent setting is definitely FDA approved for them. The FDA approval is for 3+, but the guidelines allow you to use it in 2+ or higher based on that Destiny pan-tumor trial. Pertuzumab may in the future be an option. And then this DB1303 is being studied in HER2 low expression, may also be an option for HER2 overexpression. Now, this is kind of a recap for 3+. Nothing has really changed on this slide, but I do think, again, it's important to highlight that the response to these agents can vary based on whether the patient is 2+ or 3+. And you will find that data in the respective clinical trials for review. But again, especially with trastuzumab deruxtecan, we saw very high response rates for endometrial, cervical, and ovarian cohorts who were 2+ or 3+. So in conclusion, HER2 agents are expanding and becoming more and more commonly used to treat gynecologic cancers. Proper pathologic sampling and diagnostic criteria are critical to identify the correct HER2 targeted therapy, like we discussed, between using something like trastuzumab versus more like an antibody drug conjugate with trastuzumab deruxtecan. And we are seeing the rapid expansion use of trastuzumab deruxtecan to treat gynecologic cancers and all tumors that are HER2 overexpressors.